5 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3,
2,
1.
come up front. Good morning, everybody. My name is Jens Chapman. Welcome to the Seattle Science Foundation. My good friend, Dr. Chris Chua is here, our osteoporosis boss. And it's a great pleasure to have you here, February 5th. Great topic today, the introduction of robotics and transitioning from open to, sorry, my alarm's going off. Transitioning from open surgery towards robotic and robotically aided surgery with Dr. Richard Chua from the University of Arizona, Banner Health in Tucson, Arizona. Good morning, Richard.
Good morning, Jens, and everybody up there. Thanks for having me.
No, it's an honor to have you. And again, the cool thing for me is to have the perspectives of a, I'll call you mid-career neurological surgery colleague, well-established and highly respected in the world of spine surgery and a world traveler in spine surgery, and convey your perspectives on how and why to use robotics in your practices. So as a conventional dinosaur open surgeon, I'm very compelled hearing your perspectives. That's a really important aspect. So thanks for being here, and thank you to our audience for joining us. And please do join us with the Golden Pass, the CME accreditation. We have had a number of spine surgeons do this already, so please join us. If you want to claim CME credits and you're not a faculty here, please make use of this. As always, Richard, we have a couple of cases, and so we'll start maybe with Dr. Mark Kramer. We have 4 fellows here. And Dr. Kramer is from the University of Wisconsin Neurological Surgery Program. He's going to show you a first case, and we'll ask for your erudite opinions. There are no tricks. These are just regular cases from the last couple of weeks. Okay?
Great, thank you.
Okay, good morning, everybody. So my name is Mark. I'm one of the fellows here. I'll present the first case. This case we just did a short while ago. So it's approximately a 65-year-old man. He's presenting with back pain, and his primary complaint is some leg dysesthesias on the right side, posterolateral leg, some burning and kind of tightness that he describes. It's been going on for about 4 years. And his back pain is quite a bit worse with walking and standing. He can't walk more than 100 yards without sitting due to pain. He's got a history of psoriasis. He's got a history of prostate cancer. He's been on some chemotherapy and also had some radiation fairly recently. No previous spine surgeries. And apologies, social history is actually, that's incorrect. It's just a old. So he's a fairly large gentleman. He's 6 foot. He's 105 kilograms. You can see from his exam here, he's got some mild weakness kind of bilaterally. Interestingly, a little worse on the left than the right on this examination. And then he's got abnormal sensation, both legs. No abnormal pathological reflexes. So here's his standing films. You can see a very mild levoscoliosis centered around L2-3, measured about 16 degrees. And then he's got 2-level spondylolisthesis, L4-5 and L5-S1. And it doesn't appear to be mobile based on the flexion on the left and extension on the right. Here's this MRI. It shows, and I have a cut through the foramen, both the left and the right. And on the right, you can see this would be a good reason for his dysesthesias on that right side, that 5 nerve root and traversing S1 are likely quite pinched on that side. So we got a CT when we initially evaluated him, and as expected, we saw pars defects at both 4 and 5. You can see some gas in the disc space at both those levels. And the coronal shows some pretty advanced motic changes at both those end plates. And you can see some asymmetric disc collapse, more so on the left side at 5.1 and on the right side at 4.5. And just because of his history of prostate cancer, we felt that it was worth getting an additional radionucleotide bone study. This shows no evidence of any metastatic disease throughout the spine, but there is some hot spots, if you will, at the 4.5 and 5.1 end plates along those areas of disc collapse. So in summary, it's a 65-year-old gentleman, L4-5 and L5-S1 spondylolisthesis, anywhere from, it's technically grade 1, I think. Some people are grading it up to grade 2 in some of the radiographic studies. He's got a mild levoscoliosis, and he's got right leg dysesthesias.
So Richard, straight up, this is a little bit of an unusual case. Again, hopefully no curve involved, but there's a curve in this patient, actually a 3-dimensional curve. 2-level isthmic spondylolisthesis with olisthesis, anterolisthesis, radiculopathy, and again, a very, very good guy. He's failed non-operative care. He's failed, thank you, a non-operative care for a sustained period of time, no systemic disease. You came from a, quote, traditional spine surgery upbringing. Is this something that you'd want to do robotically and MIS style, or what's your take on this?
Yeah, what a great case to start the morning. We could talk for about an hour just on this case alone. I think there's no question the patient is symptomatic. That's pretty clear. I think the treated levels that we would consider would be L4 to the sacrum. That's pretty clear. A couple things I'd like to point out. He clearly has both L4 and L5 root motor weakness. So for the residents and fellows, right, you're catching the traversing or the exiting nerve root at L4-5 because of the spondy, and at L5-S1 you're catching the L5 exiting nerve root. So that all makes sense. The real challenge is, do you go big or do you try to stay small? I, like you, was a dinosaur in the old days of open surgery, and I think you could go from an anterior-posterior 360 very easily as an appropriate treatment option. You could go anterior only with minimally invasive posterior pedicle screws. You could go all posterior only. You could go lateral or an oblique lateral at L4-5 and L5-S1 if the vascular anatomy is favorable. I think the most important decision first is, are we just doing L4 to S1, or are we going to treat the coronal deformity, which you would require to go up to at least L2, probably not higher than L2. Certainly what I've learned in my career, and I'm biased because I very early on sort of transitioned into a minimally invasive strategy, not just a minimally invasive technique, and that is to go smaller and then you can always go bigger later. And certainly that can be controversial. So I would limit the treatment from L4 to S1. I would not correct his coronal plane deformity above. I think to some degree that might be compensatory. Couldn't prove it unless we did some lateral bending in the standing position. The other thing I want to point out is, I think Mark, you had mentioned there's no instability on flexion and extension, but if you look at a supine CT and MRI, he reduces both at L4-5 and L5-S1 much better alignment than his I assume those are standing lateral x-rays. So by definition, he is unstable. I think with isthmic spondyes, lytic spondyes, a minimally invasive technique is very, very challenging because you've got all that soft tissue in the foramen. Completely different than a degenerative spondy, where if you can jack that disc space up and get indirect foraminal decompression, and you can reduce the spondy either with positioning or reduction screws or your cages. The difference here is there's a lot of crap in the foramen, and you've got to do a really good direct decompression, in my opinion, in addition to getting or achieving an indirect decompression. So, with that in mind, I would be very hesitant to do a lateral approach to inner body because you're only achieving indirect decompression of the foramen. Um, I have access to a wonderful vascular surgeon, so an anterior two-level ALIF and then flipping over and doing a posterior decompression and fusion with robotic assisted placement of screws is an option. But my MIS strategy would likely lead me to an MIS posterior only L4-5 and L5-S1 strategy. And what I've learned over the years is with isthmic spondyes and a lot of disc space collapse, I don't get as much reduction, even in an unstable patient like this, unless I put two tubes down. So I'll do bilateral tubes at L4-5, bilateral tubes at L5-S1, take out the entire facet joints, do direct decompression of the L4 root, the L5 root, the S1 root, bilateral cages, because I think I get better fusion rates in isthmic spondyes with complete disc space collapse, and then navigated robotic placement of screws. So L4 to S1, MIS, tubular retractor, inner body, robotic and navigated instrumentation.
Just on the technical point, so first of all, for the trainees on the program, I think your observations are so critical. Yes, we rely on dynamic flexion extension films, but there's so many variables to it, specifically how patients do it, whether they have a post to hold on to, whether they guard or brace themselves if they have more developed paraspinal muscles, multifidi specifically. So there are many variables, but looking at the recumbent supine advanced imaging and MRI and CT, and then looking at the upright standing films alone gives you an extremely potent and meaningful exploration of stability. So thank you for pointing that out, Richard. Couldn't agree more. The second practical question to you is, so we have a clearly two-level unstable spine. This patient has, quote, rattlers at both levels. So the spinous processes at both L4 and L5 literally just jiggle around when you open the spine up. How accurate, using the spinous process usually as a reference marker, is navigation in that kind of a setting where you have rattlers?
Yeah, that's a great question. So I think it is less accurate when you have the spinous process clamp for navigation, which is why I typically use the percutaneous pin on the PSIS. That is always rock stable. With any of the navigation companies, I believe it's FDA cleared to go up to about L2. I can tell you on an off-label use, I've used PSIS pins for navigation and gone all the way up into the thoracic spine. As long as you're taking care to match up in your own mind the navigated images with the intraoperative fluoro x-rays. So another point, even though you might use navigation, you're not going to give up your gold standard, which is a fluoro machine, bring it in and take a quick shot. But I think with a percutaneous pin on the PSIS, you can get excellent registration and accuracy with navigation.
Okay, great practical points. Let's proceed forward. So the dinosaur surgeon takes responsibility for this case. Your criticism will be much appreciated.
Very good. So we essentially did exactly as you described, went from L4 down to the pelvis. We didn't do IL screws, we did ALAR screws to reinforce the construct. And we did two intradiscal osteotomies and placed two inner bodies asymmetrically to correct that coronal curve. You can see that well on this coronal CT. And we actually initially focused our attention on L5-S1 and did a full reduction there. You can see a very nice reduction results at 5-S1. And this was after we had fully released the nerves. So we had a nice full release of the nerves at 4-5 and 5-1. prior to attempting any kind of reduction. And the reduction was done after we'd already prepared the disc base. So after the disc base was prepared, we placed the interbodies asymmetrically and achieved a very nice result. The patient did very well postoperatively.
Yeah, that's a wonderful result, and I would argue whether you're the dinosaur or the MIS or whatever, right? The goals are the goals, and you've clearly demonstrated the most important part of this operation is decompressing those 4 roots and 5 roots. More important than your correction, more important than your stabilization and fusion. I have not been able to get as good a success of correcting the coronal plane deformity by doing those asymmetric unilateral cages, but that's because I probably can't achieve as good an intradiscal osteotomy as you have done there. However, when I do a bilateral facet resection, even MIS, I seem to get some better correction, but kudos, that looks amazing. I think the patient's going to have a great result. I also, by the way, I really like your choice of staying at L4 to alar screws and not going any higher. You know, this guy's 60-something, warehouse worker. He's probably not retiring at Medicare age. This guy's probably going to keep working, and you want to keep that guy as workable as you can.
Yeah, absolutely correct. So he's an extremely active person, just a delightful individual. And yeah, we wanted to limit the fusion to the bare minimum. Did a full release, did the intradiscal osteotomies, and then put the screws in under direct division and did an active reduction, concentrating on L5 as one first, as Mark said, to have a foundation, and then indirectly reduced 4-5 pretty rapidly and found that that's actually very doable. So my partner, Dr. Skuyan, is a recent convert to robotics. He does an interesting version. He does open robotics. So he has a expensive drill guide with him. Rod, is this something you would have trusted a robot with? Honestly, Mark, you were with me, right? I mean, this was a very unstable spine. This guy was literally, I see rattling, but moving around quite ferociously. I'm not sure that the reference marker, even with a nice pelvic pin, would have been sufficient to give us more than 3 millimeters accuracy.
I think I probably would have. I mean, I think the end result is. I think the images look good. I agree with. I mean, I think you could have done an A-lift and gone posterior. You know, I think placing the hardware robotically. Again, it's done. You can do it. You know, make a midline incision, or you can do like Rick suggested. You know, an MIS approach. So I think the end result is fantastic.
One of the interesting things I might point out is at old school neurosurgeon, we actually, when I was training, we actually worked with the orthopedic faculty. So we did the decompression as neurosurgeons, and then the residents would stay behind and the orthopedic faculty would do the instrumentation and fusion. So I learned a lot of my initial techniques through the orthopedic spine faculty. So most of my career, I was sort of a decompression cage first and screws last. One of the things that can address the idea of a lot of spinal instability and motion is that you can use navigation robotics and put your screws in first. So you can do your exposure, whether it's open, mini open, or MIS, and then your most accurate navigation is going to be up front. You do your registration, you do your perk pin, you do your O-arm or whatever, and you put in your screws first. That doesn't change the ability to do your wide decompression, your corrections, your inner body. So one of the themes you'll see in my talk later is be flexible about your workflow. You may have learned a certain workflow, but you might find that over time, a different workflow may be advantageous in specific cases or maybe in all cases.
Great. So, so far so good on the downside. So he was in the hospital, I think, for 3 days, and blood loss 600 cc's is something that we did give him 1 unit of blood, I think. And he's on Humira, so he had a immune-altering medication on board that we stopped beforehand, but it just turns the tissues more friable. So that's the downside of an open procedure, but he actually clinically did exceedingly well, right, Mark? I mean,
Did very well.
yeah. So no brace and up and around, but 3-day hospital stay. So that's dinosaur land. And again, your comments are all very good, and I think there are many ways to try to slice this, but I just like open reduction, complete nerve decompression. I like your differentiation of isthmic versus general spondies, and really emphasizing the foraminal decompression and release dramatically. So Thank you. So next we have an earlier case. Who's going to go next? What did we decide? Do you have can I fill? Yeah. So Dr. Nick Minasali, proud Philadelphia Eagles fan.
Go Birds.
Go Birds.
Just, he has a very happy smile on his face these days. He's still looking for a great place to celebrate
Yes.
the defeat on the hand of Taylor Swift and the Chiefs next weekend. But Nick Minasali is originally from Philadelphia, from the Rothman system, and he is going to talk about a different angle where newer technologies were used.
Yes, thank you very much. So this patient's a 73-year-old female who presented to our outpatient clinic with acute on chronic low back pain that worsened after a recent fall, approximately 4 weeks prior to her visiting us. Basically, I think she fell backwards onto her buttock on like a slippery hardwood floor. She, at the time of her visit with us, reports the sensation of incomplete bladdering that kind of worsened since her fall. No overt retention. And then prior to her fall, she was actually already in physical therapy for longstanding right-sided radiculopathy, which kind of correlated with about L4. As far as her past medical history, she's has AFib on Eliquis, not a smoker, social alcohol use, is a widow, lives alone, and BMI 29. On exam, fully neuro intact, but she had been utilizing a walker since this fall, and prior to that, she was independently ambulatory. So we, CT from outside institution directly after her fall demonstrates this L2 incomplete burst fracture, so AO type 3, A3, with significant height loss and some mild retropulsion. But there's also this grade 1 degenerative spondylolisthesis at L4-5.
So this is a everyday case. I mean, I think, and we have the great benefit of having Dr. Chris Schuhart, who's been a Saint Schuhart, Saint Christian, here with us, our osteoporosis specialist. Literally, there's not one night that goes by where we're not getting called about burst fractures and pretty rotten spines with some degree of stenosis, some degree of deformity, spondylosis, yada, yada, yada. Let me ask you a question, Dr. Chua, and then I'll ask Dr. Schuhart to comment on that also. At Banner Health, so you have the merger of a large private healthcare corporation with a traditional state university. Is there an osteoporosis program that puts patients like this automatically into a kind of a systematic treatment program? This patient obviously is going to be osteopenic or porotic. We have opportunistic CT measurements available nowadays. This could be done by machine learning even, with some human supervision. This patient belongs into an osteoporosis program. All things aside that we're going to do, any thoughts on this being a reality in your healthcare system?
Yes, we do. You know, I struggled in private practice here in Tucson. Not all the primary care doctors are really interested in treating this disease in their patients. And in Tucson, Arizona, we have a lot of elderly osteoporotic patients. So when I came to Banner, I was pleasantly surprised. We actually have a bone health clinic that's within the Department of Orthopedics. It's run by a phenomenal nurse practitioner. And virtually every patient that I get who may need a spine surgery or spinal fusion for sure, I plug them into our bone health clinic. When I first started, I was a little concerned about, you know, taking that patient away from the private practitioner. And as you all know, in private practice, that can be a problem. But I found that the private practitioners have been very, very on board with that. And our nurse practitioner gets them on board, is very, very thorough, gets their old DEXA studies, gets them on the right disease-modifying agents, does a lot of education and counseling for these patients, which I think is as important as their bone density and their, you know, their medications. So we are very aggressive about getting them into our bone health clinic. The other thing I will do is if they're already being treated for their bone disease by their primary care doctor or rheumatology, I really spend a lot of time stressing to them how important it is to continue that bone health no matter what we do with her fracture or what we do for the fracture. You'd be surprised if you ask patients how many patients got started on their agents for osteoporosis, and they discontinued on their own without telling their doctor. So now we've got people who read about the adverse effects and hip fractures with the different biphosphonates, and they freak out, and they know all of their neighbors and pickleball partners who have had hip fractures. Most of them are from degenerative arthritis and falls, not related to biphosphonates, but they all stopped their treatment. And so there are a lot of people out there who are non-compliant and need to be compliant. So I spend a lot of time educating them about their bone health.
Very good points. So, Dr. Schuhart, we're still in a reactive phase of osteoporosis management, right? I mean, we see fractures wherever it is. The typical ones are distal radius, proximal humerus, hip fractures galore, spine fractures every night, literally now. And we're trying to treat that as good as we can. Sometimes the patients get into a systemic program. You're completely overwhelmed. Your waiting times, this is not a reflection of you because you work harder than anybody I know, are endless. Excuse me. But it's a problem. So where are we in trying to make progress into a more systematic approach?
I wish I had better news for you, Dr. Chapman. I don't think that there's been any progress at this medical center. Your colleague in Arizona, I know his nurse practitioner. I know Dr. Kelly Crone, who's I think now a part-time banner guy. And those sort of systematic post-fracture management systems are the way to go. But it takes a commitment. It takes money, it takes champion, and it really takes a belief that that fracturing is not okay. It's my opinion that there's a lot of ageism here, and that it's just okay for old people to break because that's what happens. These are cascading events. This patient, if left untreated, will likely have another fracture in their remaining lifetime, whether it's a spinal fracture or a hip fracture. The influence on this, I mean, we already know what the influence is. The patient's here, and we're discussing this patient after a burst fracture. It's very clear from the CT scan. There's trabeculization on the images. The Hounsfield unit attenuation is going to be relatively low, I'm guessing. A DEXA, if you roll through those sagittal images, you'll see the aortic calcifications there, and a DEXA is not going to give you what you want to know because it's going to be falsely elevated. Plus, I can see the degenerative spurring there at the disc space. So going with the CT attenuations is a great idea, but you really don't need that in this clinical circumstance. The patient's got clinical failure of the skeleton, and I wish we had a program, not for my lack of trying over 15 years, to try and get something together here at this medical center.
I tell you, one of the other things that profoundly influenced my ability to counsel patients is talking to my orthopedic joint colleagues, and I can't quote the papers, but both for osteoporotic spine fractures and osteoporotic hip fractures, right? It's not just the fracture management, as you've said, it's the cascading effect. And I might be wrong, but the mortality rate within 1 year of a hip fracture is something like 10 to 20%. It's not from the fracture, right? It's the pneumonia, it's the disability, it's the next fall that leads to a subdural. And I think there are a few papers, not great science, on the osteoporotic spine fractures. And again, the mortality rate within a year of these is something like 5 to 10%. And when you start to use those numbers with the health system administrators, and things like that, those save lives, right? It's just a bone fracture, but it saves lives. It keeps people out of the emergency room. I think that's the only way to kind of tackle this, but it does require a very concerted, committed systems approach. I agree.
Yeah.
So here we have an acute fracture. We also have, as a secondary pathology, a degenerative spondylolisthesis at L4 or 5 with a pretty significant stenosis, right?
Yes, correct.
So leading up to this, it's fair to say, this is not my patient, that the patient had neurogenic claudication, which may or may not have contributed to the fall. Again, stenosis patients usually assume the escape posture, meaning lean forwards. The center of gravity is in front of the hips, and it doesn't take much, together with loss of fine motor control and proprioception, to topple over. So there's a pretty high-grade central stenosis, undeclared, undiagnosed neurogenic bladder probably being a factor as well. So some urgency event, and boom, patient is down.
Yeah, and she noticed that urinary retention urgency kind of certainly worsened after this fall too.
So Dr. Chua, we have two pathologies. We have an osteoporotic compression fracture. E3 is probably a reasonable classification. And then a grade 1 degenerative spondy at L4-5. Thoughts on surgical management, or treat one pathology at the time, or treat both at the same time?
Yeah, so big picture, and sort of, again, my less is more type of approach or philosophy, I would treat the fracture first and only, and then reset and reassess how she's doing, and then consider treatment for the degenerative spondy. The history is that she has chronic low back pain. I assume that's her spinal stenosis at L4-5. Don't know what treatment she's had other than physical therapy. But her acute issue at a 73-year-old is her compression fracture, and we just got done talking about the disability and the morbidity and the mortality. So I would only treat the fracture and then reassess. If it's okay, I'll just go ahead and talk about the fracture management. For the trainees especially, we do these big whack surgeries and amazing surgeries, but remember that treatment for something like an osteoporotic compression fracture, get that tool in your toolbox. Learn how to treat that patient, because you treat that patient successfully, they're going to come back when they need their spondy and the stenosis treated. Don't give away this treatment to the interventional pain management, to the radiology. I will tell you, after being in practice for almost 30 years, my most gratifying procedure right now in 2025 is a symptomatic osteoporotic compression fracture. These patients are disabled and miserable, and virtually immediately are back to a low-level pain score. And that's very, very fun, and not fun, but it's very reassuring to see. The other concept I would have is I was doing percutaneous pedicle screw instrumentation since about 2003. Balloon kyphoplasty came out around 2007, 2008. And if you already have the technique and the 3D anatomy of percutaneous or image-guided pedicle screw access, this is a no-brainer. Balloon kyphoplasty, vertebroplasty, it's a 10-minute procedure. And again, these patients are disabled. The indications originally for balloon kyphoplasty and vertebroplasty, this was a relative contraindication when you had a burst component or a posterior vertebral body fracture because of concern of leakage of cement into the canal. But with good technique, taking your time, low pressure injection, these are very, very successfully treated, whether it's under general anesthetic, local, conscious sedation, ASC, your clinic or your office, or the hospital. So I would treat the L2 only, get into her bone health clinic, see what we can do to improve her bone health, because she may ultimately need treatment for her spondy and spondylolisthesis. The other issue about her subjective urinary retention since the fall, I don't know that that's enough of an indication to go ahead and treat the stenosis because it's part of her claudication. Her subjective urinary retention could be from pain, severe pain. So again, I would treat the L2 fracture alone and then wait and reassess on L4-5.
Yeah, I think that's a very reasonable plan. We discussed kind of that exact plan with the patient and then gave the alternative of taking care of everything at one time. Again, she was fairly debilitated, like you said, you often see. So we kind of did offer both of those options and made shared decision-making process. And so what we actually did was we decided to perform a robotic-assisted percutaneous L2 vertebroplasty, and then after that did the open robotic-assisted L4-5 with a right-sided T-lift and laminectomy with posterior instrumented fusion. We utilized O-arm and in the operating room, and again performed the vertebroplasty by basically drilling the pedicles, exactly like you said, Dr. Chua, as if you were going to place a pedicle screw, and then used live fluoro to actually perform the vertebroplasty. As you can see, there's no leakage into the spinal canal. There is some escape into the disc space, which is relatively inconsequential, likely from the fracture. And then we proceeded with open decompression and fusion at L4-5. And so she was seen at her 6 weeks out, doing very well. Pain was well controlled, not on any type of narcotics. Stable hardware at this point, stable vertebroplasty, and she's actually walking up to 3 miles at a time based on the clinic notes. So I think she does use a cane still intermittently, but overall doing much better.
That's awesome. Great result. What was her bone health, or did you treat her fusion any differently, or perioperatively, did you treat her any differently with an instrumented fusion because of her osteoporosis?
We certainly considered using like augmented screw fixation and things like that, but ultimately we really didn't change too much. But I do think keeping those things in mind are very important. And I don't know offhand if she's started any type of anabolic or bisphosphonate at this point.
I think she did, yeah.
Yeah.
She
So
did.
just local autograft was your interbody and lateral bone graft?
Yeah, we also often augment with cancellous chips as well.
So my questions here are the following. So this is a fusion surgery. Are there non-fusion options for this, in your opinion? We have this focus on MIS and less soft tissue incisions. And I'm conflicted in this, but I use interlaminar stabilizers more and more for these degenerative spondylolistheses and to preserve motion while decompressing the neural canal. So is that a reasonable option in your opinion?
Yeah, great question. And like the other dinosaurs, I've gone through all of the different ISPs. I do not think a standalone ISP where you get indirect decompression is going to be sufficient. That's ultra severe stenosis, and she's claudicating. I've seen a lot of failures where we just relied on the ISP for the indirect decompression, and we put them in a little kyphosis, which makes no sense, in my opinion, with a nearly grade 2 spondy. But some of the ISP devices where you do a direct decompression and then you stabilize, I think those are reasonable options. I think you always have to prepare the patient for, if it fails, you're going to need a traditional, instrumented L4-5 fusion. But I don't have a problem with those. I think, unfortunately, in our community, there's a bias here, and I end up taking out more of those and seeing more of the failures. But I think there's a bias in our pain community. We had a run of pain physicians putting in these devices within the last couple of years, and I think the failures have been for poor indications, not for poor technique. But I think 73-year-old with that degree of stenosis, I think if you're going to treat L4-5, I think it's a fusion of some sort. And then second tier would be an ISP clamp with a direct decompression.
So a very good final point, and then we'll want to move on to 2 other cases, and that is using image guidance and possibly also robotics to optimize fixation. So if I'm very critical here, this looks nice. This is a standard of care application. These screws are very small. So if we want to rely on screws alone, having optimal purchase would be to really get almost bicortical large caliber screws in there to try to have the best possible fixation. Do we have anything yet where we can have optimal bone fixation readouts as we're going through the imaging program, so we can kind of just see and plan our screw trajectories, since we have this virtual 3D imaging at our hands, so we have a truly optimal kind of a bone purchase with our hardware?
Yeah, I will tell you that navigation for sure, and then incrementally better with robotics. We get better fill or I get better fill of the pedicle. I think the diameter of the screws are pretty good. The lengths are reasonably good, but navigation is really, and robotics is 1 millimeter accuracy. So you can very easily and precisely and accurately and reproducibly get bicortical fixation with your pedicle screws. In fact, for instance, the first case, the high-grade spondies at 4.5 and 5.1 in a young muscular guy, I would have actually planned and executed bicortical screws for all of them. And now you're not having to rely on your tactile feel of your ball tip probe or your tap to find that cortex. So I think it can be very accurate. The other thing, again, for the trainees, I would point you to some articles way back where the trajectory of your pedicle screws, you have better pullout strength if they're convergent. I was taught to put in screws just like this, straight ahead and parallel. And I don't know that I had any failures or lucencies from that. But if you go back to biomechanics, the pullout strength is much higher if you have a convergent trajectory. Now, that is more difficult to do in open surgery with navigation and robotics because of the soft tissue and your retractors. And so one of the side benefits of an MIS approach and percutaneous screws is you get much more of that lateral to medial trajectory to put in your screws. And I think biomechanically you have a better outcome. May not change the fusion outcome, but they would look better than straight parallel screws. And I say that with a grin because in my first 7 years of practice, my senior partner used to make fun of my screws. He would look at these x-rays and laugh at me. He goes, "Rick, that's terrible. They're straight ahead, they're not convergent." And again, I didn't have any failures that I know of or not substantial, but I did go back and I looked at those biomechanical papers.
Great. Dr. Schuhart, obviously we have two major categories, speaking as a surgeon simpleton that I am, of anti-osteoporosis drugs. One are anabolic bone formers, and the other ones are anti-resorptive agents. Famously, the bone-building medications, which would make eminently more sense for us, that take a long time to get insurance approval, frequently are fraught with fights and yet more peer-to-peer reviews, following the 3D philosophy of deny, delay, defend. I don't want to be politicizing here, but that's the reality of our practice nowadays. What can we practically do for this patient to help bone healing and get her into an anabolic state of bones?
Well, the first thing I do, Jens, is I think about getting the basics right? Patient's got to have enough calcium in their dietary or supplemental intake, 1,200 milligrams in a woman in her 70s, and enough vitamin D to make sure the patient doesn't have an underlying relative osteomalacia problem, which is a different problem. It's not going to be solved by an anabolic or an anti-resorptive agent. So that'd be the first thing. Clearly, I think we would favor using anabolic therapy in this patient. Even if it was approved tomorrow, it takes time to work. This patient needed to have surgery, and so the surgery was done. I think the most important thing here is not which agent to choose. It is the understanding that this patient needs additional help going forward, right? That this is a patient who is at risk for future fractures and all their complications. So there isn't a lot you can do in the short term here except work on the basics and plant the seed, as you had discussed earlier, and Dr. Chua, I think, references to, get a relationship with a patient, they want to come back to see you, and then you can start to have the discussions for the big guns therapy that's probably needed here. So.
Great, thanks, good point.
I might add real quick for the surgeons and the trainees, what else can we do? I think sometimes these patients are having so much pain, they can't wait for the anabolic effects, et cetera. But you can certainly use potentially some bone morphogenic protein to help in osteoporotic patients. I'm a huge believer in external bone stimulators. When indicated, usually not as hard a fight with the insurance companies. And as surgeons, got to throw the kitchen sink at them in these osteoporotic patients that we're doing fusion, because we know if they fail, that revision surgery is going to be, horrible.
Great points. We have two cases left for 15 minutes. They'll be not controversial at all. Misnomer, misdirect. Cameron Hogshead is from the DFW area, and he is a Cowboys fan. He will have his weekend free without any obligation. Waste his time with football games.
Thank you. Also now a Lakers fan.
Yeah. No longer a Mavericks fan.
Exactly. We have a 61-year-old female who presented with worsening back pain and unable to really stand up straight or ambulate, mainly secondary to her pain. This was a atraumatic onset about 3 months prior to arrival. She was a previous independent ambulator, now requiring wheelchair assistance for longer distances. She has a past medical history of breast cancer, which was last called into remission, chronic kidney disease, liver cirrhosis, diabetes, and hypertension. So pretty sick gal. significant chronic alcoholism. She claims that she drinks about 10 to 20 wine coolers a day, mostly at this point helping for pain, and she's a pack per day smoker and denies any IV drug abuse. You can see on a sagittal cut of her CT scan there, just some destructive lytic changes at T11, T12 with segmental kyphosis. This is her motor strength exam, so actually isolated, no motor strength deficits or sensory deficits, surprisingly, no long track signs. You can see from basically that initial CT scan, we'll go over imaging soon, that she's got a site score, a spinal infection treatment evaluation score of 6, which is indicative of what appears to be a severe spinal infection with high probability of instability or neuroelement impingement, and surgery is recommended per those guidelines. She did have labs, basic labs with a white count showing a slight elevation at 14,000, elevated CRP, very elevated at 53, ESR of 114, all elevated. Her vital signs were stable for us, but indicative of some severe spinal infection here. Here's her CT scan. You can kind of see a degenerative scoli on top of some segmental scoliosis and kyphosis from T11, T12 spondylolisthesis vertebral body collapse. You can also appreciate on the CT scan pretty significant osteoporosis. We talked about the Hounsfield units earlier. I think at L1 she was measuring about 80, so less than 100 is problematic. And then you can also see chronic compression fractures that she already had at T8 as well as at L2. And here you can note just that chronic L2 compression fracture distal to her spondylolisthesis as well as a sacralized L5.
So this is a case that is very illustrative of the strong and stark interplay of patients' health and the spinal organ. I'm, as you know, a political activist of the first order to try to get recognition for the spine as an organ system and not a chain of bones and cartilage pieces with some nerves floating around. So this is the ill health of the patient manifested in the spinal column. The spinal organ is failing and compromising the basic function structurally and neurologically. So how do we approach this, Richard? We don't have much time here, so I had to rush you a little bit, but any thoughts?
Yeah, no worries. This is open. This is not MIS. Since the neurology is normal and I didn't see a lot of retropulsion, I would not do a necessarily decompression as a primary goal. I think stabilization is the primary goal. Infection control is the primary goal. So I would say a posterior only approach, 3 above, 3 below, nothing anteriorly. I know that certainly could be controversial, but I think you're just asking for more potential complications. That would be a 2 or 3 level corpectomy, which I think is too much surgery. So 3 above, 3 below, posterior instrumented fusion. I wouldn't try real hard to correct her. Maybe a laminectomy focally at the thoracolumbar junction, bracing, lots of antibiotics, pray. And I would tell the patient her complication rate's probably 10 to 20%, maybe even higher because of all of her comorbidities. I would probably do some cement augmentation of the screws above and below because of her osteoporosis. As far as how high and how low, again, I'd just say 3 above and 3 below and cement what you can.
Pelvis right off the bat, give them the lower end being so compromised, or try to stop a little bit shorter?
The bottom fractured level is L1.
Yeah.
And then there's a compression fracture of L3.
Yeah.
L2.
L2, yeah.
L2. Yeah. So I would go instrumentation 2, 3, and 4, and I would put cement at every one of those levels. And then I'd go instrumentation at 11, 10, 9, and maybe even T12. I think if the pedicles are okay, the upper half of the T12 vertebral body looks like it could be. And I get it, there's this whole idea about anterior column support. However, anterior column support for this patient is a 3-level corpectomy at the thoracolumbar junction. Okay, yeah, you could stage this. This is a pretty sick lady going into this infection. I would try to avoid an anterior column reconstruction, but if you have to, If she fails, then you have to go anterior.
So drum roll, not much further ado, and I think this is one of the first robotic cases done here. We did not listen to you, we did not have the benefit of your counsel. So Cameron?
We had a couple options with our robotic workflow. We had chose to do CT, or actually scan and plan. We didn't have a previous CT scan that had 1 millimeter cuts sufficient for the robot, and so we did an intra-op CT spin. So this was our workflow. We did scan and plan, the spin, AP lateral mergers with the X-ray, and then our intra-op planning, exposure and screws with spinous process clamps at the thoracolumbar region. And then we also did cement augmentation kyphoplasties of the UIV, LIV, UIV +1, and then we chose to do anterior column reconstruction with 2-level corpectomy and 3 up and 3 down. You can see our intra-op photos here. The T11 nerve root was sacrificed. This was tied off in order to gain access. Once we were able to do our laminectomies and decompression, and we used a titanium expandable corpectomy cage, as you can see there, and then you can see our cement augmentation of our UIVs and LIVs. And this is a post-op CT scan. She lost about, say, 600 to 800 cc's of blood and received 2 units intraoperatively. She is now about 5 months out and doing well, and has, just looking on her labs clinically, is mostly eradicated infection. Her labs are normalized on antibiotics, and so she seems to be doing fairly well from this, despite being such a high-risk medical candidate with her smoking, osteoporosis, alcoholism. So not out of the...
That's a great result. I'm glad you used the robot. I'm not sure why I didn't say I would use the robot, but that's a great result. And particularly the anterior reconstruction from the back. Great job.
Dr. Amir Abdul-Jabbar, our partner, has full credit for that. He was on the panel, but I'm not sure he's able to speak right now. Amir, any thoughts on this? Randy Davis?
Yeah, again, I think you made very good points in terms of, this is a very sick lady. And, you could even, in my mind, it would almost be kind of a palliative treatment, not to kind of address the infection and, really debride that very well. And then it kind of forces you into doing a corpectomy. So, in our mind, we really wanted to treat, if we were going to do treatment, we wanted to treat it robustly, and happy with the outcome. Again, we did not work on that coronal deformity. You can see in that coronal there, that was not really our main concern. It was, getting the infection eradicated, getting stabilization. And fortunately for her, she did okay.
I love, by the way, that you're kind of evaluating your learning curve with the robot in your early cases with time. How long does it take? You may not have done it with your open cases or navigated cases, but I think that shows you that even in the learning curve, because I think you guys are still pretty new on the robot, how efficient that is and how accurate it is to do, kind of a complicated, screw case.
Yeah, and just to mention, these were very diminutive pedicles. Definitely doable with fluoro, but I think in this case it was helpful getting a very accurate trajectory and comparing it to the post-op CT and really seeing how accurate it is. I think is critical to trust it. And so far we've had good results in terms of the accuracy, so I've been happy with that.
See, Dr. Chapman, Amir is a baby dinosaur, and he got on board with the robot.
He's a convert. He'll listen to your rapt attention. Last and certainly not least, Dr. Colin Gold from the University of Iowa Neurosurgical College, and he has also more complicated case. And sorry, we're shortchanging you time-wise here to about 6 to 7 minutes, Colin.
Okay, well, rapid fire. So this is a mid-60s-year-old woman with a history of breast cancer that has been in treatment for decades. She presented to clinic with progressive low back pain and right lower extremity weakness. The patient ended up having more rapidly progressive right leg lower extremity weakness and was eventually admitted to the hospital. Her past medical history, as I mentioned, breast cancer, actively on chemotherapy, and plans for radiation for some spots in the ileum. She has bisphosphonate-induced maxillary necrosis. that's been now treated. She's had 3 prior lumbar surgeries, most recently in 2022, a spinal cord stimulator in 2023, and has had bilateral foot drop since 2021. More details on the more recent surgery. It was an extension of fusion L2 to L5 with resection of an epidural radiation necrosis mass with laminectomy spanning those levels. On physical exam, the patient is neurologically intact in the uppers with weakness in both lower extremities, more severe on the right than the left, and then bilateral foot drop. Patient is at this point unable to walk independently. Numbness in the right leg throughout all dermatomes. And then there's a small picture of her low back there where she has prominent hardware. So here's some imaging. As you can see, the patient has a complete failure of this prior fusion construct with broken rods bilaterally, broken screws on both sides. There's the spinal cord stimulator, which actually enters at, I believe it was L1, L2. And then on the coronal CT, you can see this kind of ankylosed L3, L4 with collapse of the L3 vertebral body and screw loosening. And then here's another part of the CT scan, just scrolling through the sagittal, showing screw loosening. That cage is pretty loose at L3, L4. The L2 screws are pulled out and the pedicles are mostly obliterated.
So pretty devastating structural failure in a high morbidity patient with surgical and adjuvant interventional care failures on a larger degree in a, again, immune compromised patient with systemic disease.
Right. MRI just shows this fluid collection in the area.
Richard, this is something we're seeing more and more often. I don't know how it is for you, but thoughts on firsthand?
Yeah, so, you know, she's still young. Our breast cancer patients are living longer because of how good the treatments are in early detection. She needs an operation, but I would have a long conversation about what the goals of her care are. I try to find out what her length of survival is with her ongoing breast cancer, and I think that might help determine what to do. But all those being said equal, I think she should have an operation for pain control, quality of life. It's probably go big. I would take out all the hardware from the back. I'd go from the front, meaning a retroperitoneal type of approach or anterior intraperitoneal approach. Take out all that stuff, 2-level corpectomy, expandable cage, and then you could stage it and then close her and go back and do robotic pedicle screw instrumentation above and below and probably down to the pelvis. L5 looked pretty good on the CT and MRI, but I think I would still probably, you know, if you're doing an anterior reconstruction of 2 or 3 levels from the front, I'd probably go down to the pelvis for her instrumentation.
All right, drum roll. Let's do the great reveal. Pretty complex thing. Dr. Oskuyan can tell us what he did there and how this all went.
So we removed all hardware, ended up removing the spinal cord stimulator as well. It couldn't really be saved. And then we did T10 to S2AI, posterior fusion with robotic assistance. This was our workflow for the robot. We did scan and plan and transfascial perc screws at T10 to L1 with the robot, and then opened up the rest of the incision, did the actual dissection, did another O-arm spin to get the pelvis and up to about L3 or 4 or so, and then did S2AI screws with the robot up to L5. And this was interesting because we had, depending on the trajectories, we tried to get as narrow of a medial to lateral trajectory as possible for S1, but some of the pedicles, just the orientation was not, we weren't able to do it without pulling on the muscle too much, so we actually did a mixture of open and then true percutaneous for some of the L5 and S1 screws to get a reasonable angle. And then we revised the L2 to L5 screws remaining with just expanding the screw trajectories with fluoro. We expanded the L1 to L5 laminectomy, did bilateral facetectomy at each level to directly decompress the nerve roots, and then L3, L4 intradiscal osteotomy, removed the prior cage, and yeah, that was it. So here's the post-ET.
So I think, Rick, the difficulty with this surgery was these soft tissues.
Yeah.
She had previous radiation. She had a pelvic lesion as well. And I was like you, she's one of these people, I think, she's lived for so long, and she's actually was very reasonable in terms of, what her expectations were, but she was becoming paraplegic. So we really didn't have a lot of options in terms of, I think, the main thing for me, and I don't know if you have any tips or tricks, but the robot is so accurate, it's unbelievable. The soft tissue management on this, I think it's difficult to know whether to open or to do transfascial. What are your thoughts on that?
Yeah, I think in general, transfascial or percutaneous is always going to be better for accurate placement and trajectory of the screws with the robot. You avoid that soft tissue movement, you avoid the retractors. The problem is that may require more incisions. And as Dr. Chapman likes to point out, it looks kind of wonky where you have a bunch of incisions going everywhere. So if you believe that philosophy, then it might be more challenging to go back to the midline to do your decompression. You're removing a cage, you're putting in a cage. So I think in concept, it's better to do transfascial because you can do it without any retraction. I do all of my degen T-lifts, my trauma, my cancer patients with a robot. They're basically all percutaneous transfascial for the screws. So there's no retraction, there's no shift of the patient, because that's where you can get disastrous, inappropriate or inaccurate placement when you shift the tissues with the retractor or the patient shifts on the table.
And final question before we go to you, the main feature, our lecturer. Do we still need bone healing? I mean, when we do transfascial or percutaneous screws, there's no bone healing unless we do an anti-antibody cage. So what about that? And what about for these long constructs, quad rods, which has become very popular?
Yeah, so absolutely. We can't just instrument the spine. Even in this case, you should try to get an arthrodesis if she lives long enough. The good news is with the robot, you actually can do facet fusions with the robot. You can plan a trajectory, and it'll be part of my talk where you can decorticate the facet. It's almost the same trajectory as a transfascial percutaneous pedicle screw, and then you deliver bone graft into the facet joint. So we do want to do that. And these operations are not pure transfascial, transfascial. You're going to be in the midline somewhere, even if it's a tubular retractor open. So you'll have access to the midline or even intertransverse process fusion.
I want to thank Dr. Gold and our fellows for a nice presentation. Sorry we shortchanged somebody.
Great cases.
Honored to have you here. Brief introduction, Dr. Chua is a professor of neurosurgery and director of the minimally invasive spine surgery program at Banner Health University Medicine at the University of Arizona in Tucson. He's a nationally renowned neurosurgical colleague, a board examiner, politically very active in a variety of neurosurgical organizations and spine organizations. Originally, he did his internship, medical school, and residency at Indiana University. So he combines Midwestern pragmatism with advanced engineering capabilities. What makes him particularly compelling for me is that he's internationally active in a variety of scenarios. He is a faculty of neurosurgery in Kathmandu at Tooth and is the founder of the Nepal Spine Foundation and travels there. He's also been active in the Maldives, Vietnam, and Thailand. So he's really seen multiple surgical practices. And for me, it's been very inspiring to see how a very pragmatic, common sense neurosurgical colleague migrated into navigated and then robotic surgery. So we thought this would be a great occasion to hear his pathway into these, quote, new age technologies. Thank you, Richard, for taking the time and effort to speak today and commenting on our cases.
Thank you, Jens, and thanks to all the fellows. Those are amazing cases. And to Amir and Rod, I'm so happy to hear and see your early experience with the robot. Thank you specifically again to Jens and all of the SSF folks, in particular Corey. This is just an amazing forum for all of us. I can't tell you how much I learn on a weekly basis through your education, and certainly I'm happy to be here. I'm going to run through this quickly, and I want to be on time. And I know Dr. Chapman likes to poke fun of himself and is very self-deprecating, and I, like him, consider myself a dinosaur, and he likes to call me the robot surgeon. But I have to tell you that I am likewise a dinosaur, not too far removed from Dr. Chapman's training and age. But what I hope to do is show that both of us as dinosaurs can transition into robotic surgeons. So here are my disclosures. The most important of which, and Dr. Chapman highlighted this, I love learning and sharing and doing and teaching MIS. I've made every mistake possible you can make in MIS. This isn't going to be a content rich with a bunch of quoted literature. It's a little storytelling. But the key here is I want to encourage particularly the trainees, know that this is a lifelong learning process in spine surgery, and try to embrace it as quickly and as early as you can. I'm a big fan of the Karate Kid movies, and so you'll see some Mr. Miyagi pearls throughout the talk. So if you don't remember anything for the fellows, just remember the few Mr. Miyagi quotes and pearls. So again, Dr. Chapman, I am one of the dinosaurs as well. I trained in open surgery in the 90s. This is just a highlight of our lumbar discectomies open. They were in the hospital for a couple of days. They were on PCA pumps. We didn't get them out of bed until day one. That was open standard of care spine surgery in the mid 90s. We transitioned to lumbar fusions, and the residents and fellows don't know this, but there was a time where it was almost illegal to put in pedicle screws. There were some investigative reports that showed some bad surgeons were doing bad things with pedicle screws, and then all spine surgeons got a bad name for putting in these horrible things called pedicle screws. At that time, the typical technique was an open Cloward Pliff technique. The ALIF technique was coming around, and that led to the cage rage, which was both good and bad for our specialty. But you can look at the normal standard length of stay for a one-level degenerative fusion was almost a week, fully catheters, PCA pumps. And again, in my training, I learned how to do my arthrodesis and instrumentation from our esteemed orthopedic faculty. And I think it benefited me because we learned very early on about biomechanics, tissue handling for arthrodesis, and all of those things that we were not taught in our neurosurgery training. So how and why did I get interested in MIS? Purely by accident. First year of my practice, I'm collecting my cases for oral boards. We have to list all of our operations and complications. We have to list in detail immediate and 3-month results. And I noticed for my lumbar discectomy patients that most had some sort of incisional pain. And when I asked them to show me where their incisional pain was, it wasn't the incision, it wasn't their radicular pain, it was all upper buttock pain. I had no idea what that was caused from. As a neurosurgery resident, we spent very little time in the clinic, so we didn't see our faculty's post-op patients. So I didn't know what this incisional pain was. And about that same time, the literature was starting to come out with endoscopic tubular retractor type discectomy. Some of these are well-known people, some are not. I certainly was a big fan of Kevin Foley from Sims Murphy very early on, and I decided to check out the MIS tubular retractor approach. I bought in very early on, so this is circa 2001, 2002, the idea that an MIS strategy is a small approach portal, limiting the soft tissue retraction, the coagulation, the stripping. You can still use magnification illumination, and you still need to use fluoroscopic localization. And so I started adopting MIS technique with an endoscope in 2003 with herniated discs. I tried to set myself up for success with a new, a technique and technology, and that is left-sided symptoms only. I'm a right-handed surgeon, big L5S1 discs, thin, skinny people, no psych issues, no workman's comp, and I set a goal, 10 to 15 cases. Let's see how it goes. Well, as an old school neurosurgeon, I didn't know how to use an endoscope, right? And so I tore the dura 2 out of my first 3 cases because the original technique was an endoscopic technique. And certainly these are the words that got uttered or in my OR, quit, never going to do that again. Well, that's terrible. That's no good. This technology's terrible. I blamed it on the technology. And then I took a little bit of time to think about it. Happened to run into Kevin Foley at a spine meeting. I said, listen, I believe in this thing. I really want to try it, but I suck. I tore the dura twice out of 3 cases. He said, just wait. You're a neurosurgeon. You don't know how to use an endoscope. We're coming out with new retractors, new instruments. You're going to go back to the microscope. Now it's a fancy microdiscectomy. So I said, okay, I'll give that a try. I set a goal for myself, 10 to 15 cases. I was hooked within 5 cases. And the reason is that upper buttock incisional pain that most people had, completely gone. 100% gone at their 2-3 week visit. So now microdisc patient comes to my office 2 to 3 weeks later with 99% pain relief. Not 80, not 70, 99% pain relief. And so the first theme of that experience is, for the trainees especially, make sure you do what we call an iterative cycle for learning. Analyze the potential of a technique or technology, simulate it if you can, do it, collect your own data, your own observations, put it back into your computer for machine learning and predictive modeling, and rinse and repeat. So in other words, prove to yourself why you can or you can't develop a technique or a technology and get the benefits that other people say they get. And so the first Mr. Miyagi pearl is wax on, wax off. Repetition, numbers is very, very meaningful, especially when you analyze your own results, both good and bad. So my early observations for MIS eliminated the incisional pain. I believe it's just from that little stripping with the cob and stuffing a retractor in there and pulling the retractor. And we now know there's good biomechanical evidence, there's good MRI evidence, and there's functional evidence that just that little stripping and retraction causes scar tissue in the multifidus, leads to weakness in the lumbar extensor muscles, and there's biomechanical evidence of muscle protein breakdown during an operation with an open retractor compared to a tubular retractor. MIS showed equivalent or superior relief of pain, not that drastic a learning curve if you take your time. It's more efficient, it's faster, less time for exposing, less time for closure. Hemostasis and visualization are initially challenging, but they are equivalent to open techniques. But as you do more, then you need to realize that, well, what if I have a durotomy? How am I going to take care of it? What am I going to do about postoperative hematoma, seroma? Because the advantage of MIS is no dead space. The disadvantage of MIS is no dead space. So if you get a seroma or hematoma, you may get symptomatic. So over time, I understood, drank the Kool-Aid, believed the philosophy of MIS is a philosophy of a technique. It's not the size of the incision. It's not the specific retractor procedure or technique. I can take MIS philosophy into any operation, even some of those great cases that you showed, trauma, infection, and deformity. So I like to think of MIS as precision targeted surgery. So how am I going to deal with a durotomy with MIS? Do we close it? Do we not close it? In the open technique, I would argue we try to close it because we've got some dead space to reduce our risk of CSF leak and pseudomeningocele. And there are a lot of ways to close it. Allograft muscle, tissule, fibrin sealant, primary closure, no closure. When I decided to learn how to close it primarily through a tubular retractor, I realized that patients could still go home the same day, no bed rest. I have the same durotomy that everyone else has, this durotomy rate. I have a 0% rate of taking them back to the OR for recurrent CSF leak or pseudomeningocele. So I thought, well, I should try to master primary closure of these durotomies through a tube, because if I do that, I can do bigger durotomies, i.e. intradural pathology. And so that led me to transition into learning how to primarily close the dura. There was a device long ago that was this nitinol clip. You can see examples of a small durotomy or a large durotomy for a nerve sheath tumor where we can primarily close the dura in a watertight fashion. That unfortunately is off the market. Then I had to learn how to use other tools. So dural closure kits, knot sliding devices, suture tying devices for working in a small ergonomic workspace. And then most recently, there is a device called the Durastat. And here's a very, very short video. This was designed, invented by Kevin Foley, again, a neurosurgeon working with technology and some smart engineers. So it's a nerve hook bayoneted device that you simply deploy the 6-0 needle and PTFE suture from inside out. You pull the suture out, you deploy it on the other side, pull the suture out, and then you tie the knot extracorporeally, so above the tubular retractor, and then you have a knot slider that just slides the knot down. And so just with a couple of cases, you can be very, very efficient for this technique. This was a thoracic meningioma I did about 6 weeks ago to show that this device is very, very nice. Well, before we close the dura, we've got to be able to see the dura. So I learned a technique of tacking up the dura with just 4 neuron sutures, but how do we get that expansion of the dura? So just before it got published, I decided to then take a smaller diameter tubular retractor, push it down, and that tents out the dural retraction sutures and gives you an additional 1 to 2 millimeters of dural exposure. So here's a meningioma of the thoracic spine with a dural exposure, dural tack-up sutures, and a smaller or a double tube technique to tent the sutures out. So the theme again is learning a new technique, adapting to the technique, but waxing on and waxing off. Got to do a number of cases and reps to get good at it. Here's that thoracic meningioma I did 6 weeks ago. Here's a C5-6 meningioma that I plan on doing next week through a 20 millimeter tubular retractor. So we were able to publish this series of 24 patients, one of the largest series early on of intradural tumors with an MIS technique. Compared to some other large centers, we had equivalent or superior results. Most importantly, no complications technically, no CSF leaks, no pseudomeningoceles, very, very short length of stay, so 2.2 days for MIS intradural, cervical, thoracic, and lumbar tumors. So then for the residents and fellows, you should add these technologies as you go in your career. So I added navigation in 2003, percutaneous screws in 2003, MIS tubular fusions 2004, and then varying degrees of different interbody fusions. The Mr. Miyagi Pearl here is, first learn the basics. So don't go right to an MIS tubular retractor 3-level fusion if you've never done an MIS discectomy or laminectomy. Learn to stand, then you can fly. That's nature's rule. It's not my rule, but I think that makes a lot of common sense as you add technologies all the way up to robotics. You can take those technologies and skill sets and apply them to a broader degree of indications, and this is just a list. But as you add these techniques and broaden the indications, you realize you start to combine techniques and technologies. So ultimately, for about 15 years, I've been doing MIS, navigated, tubular retractor, interbody fusions with expandable cages. So what was the next technology to add? Robotics. Additional MIS skills that I think can be helpful for surgeons, whether you do a lot of it or a little of it. I think it's good to have that technology and technique to advise our patients because other surgeons are going to be able to offer these. Since 2018, I've added robotics to all of the techniques, whether it's open surgery, MIS TLIF, direct lateral, OLIF surgery, trauma, infection, and cancer. I still do a fair amount of ALIFs, but I combine those with sometimes percutaneous robotic fixation on the backside. And then ultimately, you want to be able to promote yourself and your patients in your practice. So during COVID, I was able to wrap all these technologies together and offer outpatient lumbar fusions for degenerative spine patients on an outpatient basis when we couldn't admit patients for almost several months because of COVID. And so the next Mr. Miyagi Pearl is ultimately you create your own way. So one day, once you feel like you've mastered the technique and the technology, you've evaluated your results, you've managed to change and adapt your technique, you'll be able to do it your own way. And so now I've become known in our community for the guy that can do outpatient lumbar fusions and patients go home the same way. The overall philosophy of that, of course, is this idea of the technology adoption life cycle, which I took from my Midwest roots, which actually came about with farming. But the idea is most of us, when we see and hear about new technology, we're on the far right side. We're a laggard, we're skeptical, we may be super, super conservative, but the idea is we don't want to necessarily take every new technology and apply it to everything right out of the gate, which are the enthusiasts on the left side of the curve. we don't necessarily want to be all the way on the right side of the curve. I would argue as you adopt technologies in your practice over your career, you should try to make yourself go from the right side of the curve to the left side of the curve. So why not consider outpatient lumbar fusion? If we combine minimally invasive techniques, surgical navigation for accuracy and efficiency of pedicle screws, robotic-assisted planning for additional accuracy and efficiency, and now being able to do the actual facet fusion with a robot. And then I learned from some spine surgeons like Mike Wang. We learned from the OB and the orthopedic surgeons, ERAS protocols. We can and should accomplish transitioning some of these at least degenerative populations and surgeries into the outpatient world. This is our initial cohort of outpatient fusions done over the COVID time, and just quickly 20 or so patients, T-lifts, PLIFs, O-lifts, 1, 2, and 3 levels. Didn't take us more time than usual. And these are all done as outpatients with the exception of a couple of urinary retentions. These patients all went home. And so now with that experience, I've transitioned to moving 90% of my spine surgery practice to the outpatient world, so that now greater than 95% of my posterior cervical decompressions for amyotomies, laminectomies for stenosis can be done as an outpatient. Thoracic decompression for synovial cyst, stenosis and myelopathy as an outpatient. Virtually all of my lumbar decompression, discectomy, revision, up to 3-level decompressive laminectomies as an outpatient. Greater than 80, about 85% of my up to 3-level degenerative lumbar fusions are done as an outpatient. Again, taking advantage of the MIS philosophy, navigation, robotic assistance, ERAS protocols, and most importantly on this, that's not on the slide, patient education and expectation. Our patients expect to stay in the hospital and get taken care of by our nurses after surgery. We know that we're resource limited now with human population and our human workforce. Patients do much better at home with their family sleeping in their own beds. So with few exceptions like A-lifts, most of my posterior operations are done as an outpatient. And again, percutaneous instrumentation and robotics happens to help that, as well as patient-specific rods. And so the next Mr. Miyagi pearl is, remember though, you have to use these technologies and techniques appropriately. And while I've kind of run through a career's worth of adding technology and moving from open spine surgery to MIS spine surgery, you still have to go back to your basics. Just because you have the license to be able to do it doesn't ever replace the eye, the ear, and the brain, as Mr. Miyagi says. And so with those fabulous cases, as you notice, my comment started with, are the indications appropriate for surgery, not what surgery do we do? So then with MIS and navigation robotics, we know that it's a little bit more technically challenging for trauma, deformity, tumor infection, but with experience and you all, and particularly Rod and Amir showing those great cases, you're rapidly taking the technology up the learning curve to apply to these. And I think that's a robust way to offer these to our patients. And where we're at, we have a multi-center trauma, level 1 trauma center, multiple organ injury patients. So we can offer minimally invasive, percutaneous, robotic, navigated, instrumented fusions, and they can go on with their rehab and care with their other life-threatening conditions. The biggest advance recently is the ability to do facet decortication and fusing with the robot. This was first reported by Izzy Lieberman, Ron Lehman, Chris Good, and others, and Jeff Gum. And this is a real fast video, but essentially you can use the computer software to plan not only the placement of your screws, you can plan your inner body cage and local reduction deformity correction, but you can plan with the software and execute a facet decortication on the, let's say, contralateral facet, contralateral to the approach of a T-lift. So answering Dr. Chapman's question about fusion, we're actually going to do a facet fusion. It creates a 7.5 millimeter diameter trajectory up to a 20 millimeter hole into the facet, very accurately, very efficiently, MIS, percutaneous, and then we backfill that decortication defect with 2 cc's of bone graft. And as I talk, this video will just show in an animation how we make a percutaneous incision through the skin and fascia, and then the navigated dilator is going to come in just to localize, make sure we're right at the trajectory. And then we're going to go down with this decortication tool, which is essentially just going to drill out a column of bone. And literally this takes about 30 seconds. And once we've drilled the hole, we pull the bone out. That acorn bit is designed to pull the bone out as it drills forward. And then once we drill that hole, we're going to backfill with bone graft. So now the idea is that maybe we can use that tool to do the decompression. So computer planned robotic executed decompression. Can we do the facetectomy? Can we do the laminectomy using the robotic technique so that it's no longer just an expensive drill guide, which is a very, very appropriate criticism for robotic technique up until this year. And so if you look at these diagrams, maybe I can use the robot to plan and execute the decompression in that sagittal and posterior and axial plane. Can that make me more efficient? This is looking down a 22 millimeter tubular retractor right-sided for L4-5. That's the right L5 pedicle, that's the midline, and the red circles are potentially trajectories that I could do with the computer software and execute the decompression with the robot. That's what it's going to look like after the decompression, and all that's left is ligamentum flavum. There's no more bone left. There's the pedicle, there's the midline. That's a little bit of the lateral facet left over, a little bit of the L4 lamina, a little bit of the medial aspect of the L5 lamina, but the rest of the decompression was done by the robot in a very efficient and accurate fashion. And that total amount of decompression is what we would normally do for access for an open or an MIS TLIF. But now we can do most, if not 90% of the decompression with the robot. And that's what it would look like with a wide decompression of the canal bilateral. Cage is put in, and there's that decompression predominantly done by the robot. I'd like to end with a couple of cases using software also to learn from my great colleagues at SSF deformity correction, even for 1 and 2 level. I'm tired of being criticized for putting patients in a flat back with MIS 1 and 2 level TLIFs. So I've learned to try to optimize PIL mismatch and optimize SVA even in a 1 level L4-5 degenerative spondy. Here's instability on x-rays and MRI. Here's what the computer plan looks like. So not only can I use the robot to plan my pedicle screws with that very nice lateral to medial trajectory, I can plan at L5 bicortical screws, but the green trajectories are the facet fusion on patient left or picture right, and those 4 green trajectories are to actually do the facetectomy and laminectomy. This was my very first case, so I didn't plan to go all the way through the lamina and facet because I wasn't sure about the accuracy, but now I plan to go through the entire bone, facet, and lamina because I've got usually a thick ligamentum flavum to protect the thecal sac. This is what it looks like on 3D and sagittal images, and that's what it looks like intraoperatively using that acorn bit to essentially do the entire decompression with that drill bit. So it minimizes using a burr once I put the microscope in and tube. It minimizes using kerosene rongeurs and getting an adequate MIS TLIF. Well, how about for a 2 level? Again, trying to respect deformity correction, optimizing PL mismatch and SVA for an older patient and significant thoracic kyphosis. This is a patient with degenerative instability at L4-5 and stenosis. She also had spinal instability at L5-S1 on flexion and extension x-rays. So again, planning not only percutaneous MIS pedicle screw placement, but facet fusion as well as the decompression. And on these axials, you can see at L4-5, I'm doing a facetectomy, ipsilateral, and contralateral laminectomy because of the stenosis at L4-5. But at L5-S1, I just need a facetectomy to gain access through Kaman's triangle to do the interbody fusion. So I can very specifically plan the decompression, placement of screws, and ultimately, hopefully someday, placement of the rods in the expandable cage using the robot. And that's what it would look like on the table postoperatively. Adequate reduction of the spondy at both levels, wide bilateral decompression, percutaneous placement of convergent pedicle screws with expandable cages, and improvement in the lumbar lordosis. And again, the last two cases are traumatic indications. Most recently, L2 burst fracture in a high-speed vehicular accident, fortunately neurologically normal. This is probably stretching the indications, but I decided to do a 2 above and 2 below percutaneous only traumatic pedicle screw fixation and facet fusion. We mobilized this patient much quicker. She had a spleen injury and an X-slap, no bracing. This patient is now about a year out and doing phenomenally well and has a solid facet fusion at all of those levels. L5 burst fracture recently, high-speed vehicular accident, kind of an unusual seatbelt injury, presented with severe low back pain, radicular left leg pain, and a complete foot drop. The injury is isolated to this vertebral body, so we thought we would try a minimally invasive approach with the robot with percutaneous placement of the pedicle screws, but a tubular retractor reduction of the fragment. So that's an 18 millimeter tubular retractor, hemilaminectomy at L4-5, take a bone tamp sitting on the back of that retropulse fragment, tamping it down under the microscope, and then ultimately you see, it's hard to see on these photographs on the left, that's the retropulse fragment with the nerve root and thecal sac retracted. That's the bone tamp top right, tamping it down. There's the thecal sac back in position. Here are the intraoperative x-rays. There's reduction of the bone you can see on the postoperative CT scan, and the patient's foot drop resolved within about 3 weeks and complete relief of the pain. So the point of these two last cases is taking those strategies and technologies, especially MIS combined with navigation, with robotics, deformity correction, pelvic parameters, and spinal deformity numbers. And ultimately, the robot now can do the decompression and isn't just the very expensive drill guide for our percutaneous instrumentation. And I know a lot of you in Seattle are electric and hybrid car users. And again, I'd like to remind people that over 90% of Tesla cars are built by robots. And if you believe in the technology and you believe in enough that you buy a Tesla, use a Tesla, or you ride in a self-driving car, then you should consider adopting these technologies in your work environment, including MIS, navigation, and robotics. And so with that, I'm going to close with what led me to have a successful MIS practice, fully invest in the life learning process. It's iterative. My father, a retired radiologist, told me when I graduated from neurosurgery, you're just graduating from kindergarten. You don't know anything about neurosurgery until you practice about 5 to 10 years. Consider getting out of your comfort zone. Have the courage to make mistakes. Try not to make the mistakes with decision making, but there can be decision making mistakes and technical misadventures. Don't expect to succeed immediately. There's a learning curve for everything. Critically analyze your own failures, but more importantly, your successes, so you can adapt them, refine them, and improve them. And so the final Mr. Miyagi quotes are, just remember, true strength comes from the inside. It's not the robot, but how you learn how to use the robot. Trust the quality of what you know, not the quantity, although quantity and reps are important. And most importantly, try to avoid the barriers to adoption. I don't want it to slow me down. It costs too much. It doesn't apply to me, or I'm already too good and I'm too fast. Most importantly, we talk about surgical innovation. Innovate yourself. That's how you're going to maximize your career and your adoption of technology. And I've certainly talked about successes in my evolution as an MIS surgeon, but here are my current failures. I suck at doing the laminoplasty. I get great results on the MRI scan, but I've got too many C5 palsies. I'm trying to do better at that. I have too much postoperative pain, way more than I anticipated. And I don't know that I'm going to be able to become a spinal endoscopic surgeon. I think at my stage, it's too steep of a learning curve. I'm not convinced the endoscopy supports the literature is better than my MIS results. And I certainly am not probably able to turn my old dinosaur brain and robotic brain into the ergonomics, the tactile feedback, and the visualization disadvantages there are with spinal endoscopy coming from an open and MIS career, but I'm still working on it. And with that, I apologize if I've gone a little over time, Jens. I appreciate everyone's attention. And again, I truly am honored to participate in this. And for the fellows, wonderful cases. Good luck in your future careers.
Great stuff. Thank you, Richard. So, given the time limitations, there's one or two questions. Maybe Rod has one also, or Amir. But the first and foremost thing is, so you moved from private practice into a large healthcare system that is both a healthcare corporation, a not-for-profit, I assume, and a university practice. How did you sell to administration the added cost of robotics? Was it greater efficiency, shorter length of stay? What was the premise into which this additional significant ongoing, given licensure and royalties and maintenance and extra technology, supporting staff, how did you get that sold to them?
Yeah, real quick. So to get it sold in a private practice, I had to convince the administration that it was a marketing tool, because that's what they understand. I got them to understand that a robot spine was new in the community. It goes well with robotic bariatric surgery, total joint surgery. And so from a marketing standpoint, they could recoup the benefits of added volume. When I went to the university, that was an easy one. The private practice discontinued the robot service contract. They took away the robot. I went to the university where I already had operating privileges and I was a voluntary faculty. And I said, if you get me a robot, every one of my spinal fusions comes immediately to your hospital. That was somewhere between 75 to 100 cases a year. And I said, if those cases come, then ultimately my entire practice comes. So you do have to understand the lingo and the numbers to work with administrators to get new technology. They understand numbers, which is volumes. While they say they care about length of stay and decrease infection and accuracy, what they really care about is volume of surgeries. And sometimes we have to fib a little bit on convincing them about acquiring new technology because of the cost. But at the end of the day, it does reduce our length of stay and complications.
In that video, by the way, the robots are not doing so well against the dinosaurs. Dinosaurs are they're creating a lot of mayhem there. Rod?
I mean, I think, we've talked a lot, and, I've just started using the robot, and I'm having a great time with it. Obviously, there's like we've talked about, I think it's in its infancy. I think doing the decompression, I think the soft tissue management is still to be figured out. I think, it's only going to get better and better. So I'm excited, and I'm really blown away by how much to get to where it can drill and do all these other things, it's truly a game changer.
My goal, and I don't have any inside knowledge, my goal is before I retire, it's going to autonomously do the drilling. So I'm just going to take, just like stereotactic radiosurgery, I'm going to take the MRI and CT, I'm going to sit in my shorts and tank top at home on my laptop, I'm going to draw little circles on the bone and disc removal, upload that to the robot. The robot then I'm going to hit a button, and the robot's going to autonomously move and do the drilling. And it's 1 millimeter accurate now. It's only going to get more accurate when we start putting force meters and things like that on the tip of the end effector.
You've been a visionary colleague and a very patient educator, and we always appreciate hearing from you. And the term Mr. Miyagi pearls will be supplemented by Dr. Chua pearls in the near future. That's how much of an impact you've had globally. So thank you, Richard.
Thank you. Last plug for the Nepal Spine Foundation. I just posted it on LinkedIn. I'm going to do the trek to Mount Everest Base Camp this April for my 60th birthday. April 20th through May 2nd. It's not rock climbing, it's not mountain climbing, it's not ice climbing. Encourage anyone who's got the time and to take and go with me for my 60th birthday, a little bucket checklist of climbing to Mount Everest Base Camp.
Bucket list, it's a great experience. I wish I could go, but I'll watch you, and we'll look forward to hearing from you when you're safely returning. Take care, Richard.
That was a great time.